Hello, my name is Mike, and I'm going to be doing a quick video on a patient, a geriatric patient who is had some pulmonary complaints. This patient ID identification was PO. She was born in 42, and she's a 72-year-old Caucasian female who presented to the clinic unaccompanied and appears to be a reliable historian. Her chief complaint was she was here for a wellness exam. However, she also stated that she had some peripheral or dyspnea on exertion recently. So, quick HPI, patient, 72-year-old female, presented to the clinic for her annual wellness exam and complaints of a 3-week history of increasing shortness of breath with exertion, stating that her breathlessness is getting worse while she's going upstairs or carrying her groceries in. However, she does state that that does resolve at rest. She's also noticed that she's been having a cough over the last 3 weeks and some lower swelling in her ankle regions. Patient denies or states that she's had kind of a low-grade fever over the past couple weeks as well, but that resolves at night. She denies any associated chills, weight loss, night sweats, or any other additional complaints. She denies any chest pain, dizziness, or lightheadedness as well. She also states that she doesn't believe any of these symptoms are changing or affecting her activities of daily living that she can notice. She has a small medical history with some general anxiety disorder, along with insomnia and hypertension, along with dyslipidemia. She's had a few surgeries, carpal tunnel, right rotator cuff repair, and a hysterectomy. She states allergies to morphine and Toradol. She does take a few medications, of which are alprazolam, zolpidem, amlodipine, and atorvastatin. Chemical history, social history, she denies any tobacco or e-cigarette use, denies any alcohol or illicit substance abuse. Family history, her mom died at 60 from a brain tumor, and her father passed away at 65 from a heart attack. Basically, the review, subjective review of systems, she denies any weight loss gain, denies fatigue, states the occasional low-grade fever. HEENT was all negative. Cardiovascular was negative with no complaints other than the pitting edema and the shortness of breath on exertion. Pulmonary, she does report a cough that began 3 weeks ago, is intermittent and non-productive. She denies any wheezing or orthopnea, and she states that the shortness of breath goes away when she's at rest. As far as the GI and GU, she's got no complaints, along with neuro or the lymph systems, and endocrine. She denies any recent anxiety attacks, depression, or self-harm. Her vital signs are very stable. Her blood pressure is well controlled at 132/76. Her oxygen room air sats are at 95%. And she's got a BMI of 28.8. So the subjective review of systems: alert and oriented, no acute distress, appears healthy, good hygiene. She's normocephalic atraumatic. She's got no abnormalities with adenopathy in the cervical or supraclavicular region. Trachea is midline, no JVD noted. Cardiovascular, regular rate and rhythm, S1, S2 appreciated with no clicks or murmurs. Pulses are equal in all extremities except for the 1+ pitting edema, and no evidence of JVD. Lungs are clear with good symmetric and expansion. They're even and non-labored. She's got no use of accessory muscles, and no evidence or no stridor, grunting, or wheezing was appreciated. She's got normal ataxia, normal gait. She's got symmetrical without distension. Normal bowel tones are appreciated in all 4 quadrants. No masses or splenomegaly noted. So the differentials that I came up with were, the first one was congestive heart failure, based on the fact that patients got several symptoms suggestive of heart failure, specifically the shortness of breath and DOE with mild lower extremity pitting edema, and that worsening at the end of the day, which is consistent with the fluid retention, and a possible reduced cardiac output, both of which are key features of congestive heart failure. Additionally, I went with chronic obstructive pulmonary disease. The rationale for this is that the patient denies a chronic cough. However, recent intermittent non-productive cough for 3 weeks is noticeable. The increases of shortness of breath with exertion that raises some concerns for COPD, especially since the patient denies shortness of breath at rest. According to the World Health Organization, people with COPD can have lungs that get damaged or clogged with phlegm and have symptoms that include cough, difficulty breathing, wheezing, and tiredness. Although this patient denies a history of smoking, she did have a stated exposure to secondhand smoke from her husband, of which they've been married for 42 years. Lastly, I went with acute bronchitis. The rationale was given this patient recent history of intermittent cough that started approximately 3 weeks ago and shortness of breath with exertion that could potentially account for this differential. However, given that the fact the patient denies any history or previous history of pitting edema and the fact that she has it, this would typically not present with chronic bronchitis. So kind of went with the congestive heart failure. So diagnostics are blood samples of BMP, EKG, chest x-ray, CBC stress test, and echocardiogram for diagnosis. Treatment was deferred at this time, given that she was in no major or acute distress at all. And so the only thing that we elected to do, or the physician elected to do, is start her on a 12.5 milligram dose of hydrochlorothiazide. We did send her out for referrals to cardiology and an echo to be done. Education on the patient, gave her the importance of having her blood work done, the diagnostics performed, and following through with the cardiology referral. We also educated her on daily weight measuring for signs of increasing fluid retention. And we talked about dietary changes with respect to salt modifications. And then so in addition to her complaint of DOE, she was also there for her annual wellness exam, which everything other than the complaints of the new pulmonary complaint, everything was good. We did have her previous labs. Her cholesterol levels were well controlled with her 20 milligrams of atorvastatin. And according to the ACOG, she is due for a mammogram, which we did schedule. So follow up with respect to that, we recommended the patient return within 1 week to assess the effectiveness of the diuretic and to follow up on any lab results. Additionally, the cardiology referral is confirmed for the appointment for her for the next day. She was able to get in that to get an echo done. We discussed increasing intervals of routine follow-ups, visits every 3 to 6 months to monitor reversing symptoms and long-term care of CHF. Lastly, we highly recommended or encouraged the patient to seek emergency medical treatment if her symptoms of shortness of breath increased or if she started to feel any form of cardiac pain or dysrhythmias.